I can't see the chat function, so I need your support, Nuala, there. But can
No
everyone see
problem.
my screen?
Yes, we can.
Excellent. Right. Okay. So just move this. There we go. Okay, so my name's Ishaq, as Noel introduced. I'm a lead pharmacist and I have an interest in chronic disease, especially diabetes. I'm currently doing my master's in it at the moment. And in our practice in Limelight in Old Trafford, so we were quite good with our diabetic patients. However, what we found a lot of our patients were not going to the type 2 diabetes prevention program. So that's a referral that is naturally done for those that have been diagnosed with type 2 diabetes. And we had a very low attendance rate. So myself and the practice nurse, we had a discussion to see what can we do to help improve this. And I went to a conference and I really, really enjoyed it. And it's by Public Health Collaboration UK. And they are very big on low carb, so that's kind of their message. But put that to one side, I really liked the principle because it was the first conference I went to where medication wasn't talked about, which I found such an interesting concept. And then the food that was served. Normally, when we go to a lot of these education conference, you see all the nice food, the cakes, the pastries, but in this particular conference, it was all really healthy, nutritious food. And so I was quite influenced in terms of that particular conference that I attended. And I do recommend if you can go to it. They do it normally once a year in Solihull. And it's really, really interesting. And I'll try and share the details to Noala if she wants to share it to the rest of the group. And one of the doctors was talking about group consultations that they did down south. And it was really, really interesting. So did a bit more work and I did a research and I thought, okay, there's a lot of good pockets of practice happening up and down the country. So let me try and implement it locally in our practice. So this is my happy place. I'm sure everyone's got one. This is in Lizard in Cornwall, one of my favorite places, which I go every year with my children. And that's where my brain goes into overdrive in terms of planning different events. So at this particular moment, um, we got one of the ambassadors from the Public Health Collaboration UK who volunteered, and myself and a practice nurse, we identified and recruited suitable patients. So what we did for the first one, and we've run these now several times and the numbers are a lot bigger, but the first time we done it, we capped the numbers to 10 because we just wanted to manage expectations and we started with low risk patients. And by low risk, what I mean by that is those that are type 2 diabetic, those that are pre-diabetic, those that are prescribed metformin, and that's it, and potentially SGLT2. But if anyone's on glycoside or GLP-1s or insulin, then we would exclude them. But in this particular cohort, we didn't have anybody on SGLT2 because there is something in the guidance about low carbs. You've got to just be a bit more mindful with those patients. And so we recruited the patients, and what we did was through Accurix, we sent a message out to the patients that we identified, and we asked them to respond. And then, as a result, we gave them an overview of the program, and then we invited them through like an introductory discussion. And then we had different forms that they had to sign, such as confidentiality, patient confidentiality. They're happy to discuss their results, etc., with the group, and those that don't want to, we have to be mindful of that. And so once we went through the agreement and we gave the overview, it was a 12-week program. So what we did was at the beginning, we took everyone's parameters. So before we started, we took everyone's bloods, and by blood specifically the full blood count, liver function, lipids, HbA1c, and blood pressure and the weight. And what we said to the delegates was that we will measure the weight and the blood pressure every 4 weeks, and then at the end of the 12-week program, we'll recheck the bloods. Especially with HbA1c, we want to wait at least 3 months. And most of these patients that attended were from within the community. And so what we found when we asked them, like, what were the barriers for you to attend these programs? So a lot of these programs are done online. So a lot of them didn't have technology. Some people struggled for transport for where their training was happening in the education sessions. So we were kind of thankful that we were able to deliver this locally for our patients that live on a doorstep. So when we realized that this was a barrier now, and we are going to a digital age and we got to embrace technology, but we must not forget those patients that have these health inequalities and these barriers from, not having the means to be able to access this. And so we divided it into a 2 weekly learning on lunch program. So there was myself and the practice nurse, and we will be there with our EMIS laptops, and we'll get the patients to sign in, and then we will have different speakers to discuss different topics. So the week one was around understanding diabetes and type 2, and we talked about carbohydrates and how to get started and educating about different meals. And then week three, we talked about understanding elements of a healthy diet and meal ideas. And what was really, really enjoyable with this was in the practice I work at, we have a kitchen downstairs. And so, we managed to be able to cook some healthy meals for for our patients, and they were able to taste lots of different healthy, nutritious food. And the ambassador, when she used to come every 2 weeks, she would bring in homemade baked healthy bread or healthy, snacks. And people were quite interested actually how nutritious and how tasty it is, but being healthy at the same time. And in a week five, we got a local gym expert, and he did a session around healthy lifestyle and exercise. We had a mental health practitioner that came in and talked about sleep hygiene. And the more and more I research about sleep is so important, especially for people in the weight loss journey. And I didn't realize that it's your sleep and how it impacts you can have an impact in your eating habits. So it's really important to talk about sleep. And then we talked about healthy lifestyles such as stress, and managing stress, because that has an impact as well. And then at week 12, we did progress reports, and we had a big party at the end of it. So this was kind of the tree, as we call, for insulin resistance, and the root cause of it is there's several things such as refined carbohydrates, lack of sleep, ultra processed food, chronic stress. So there's a multimorbid approach here in the regard that people seem to think with type 2 diabetic patients that it's as simple as eating healthy and exercising, but there's a lot of variety of factors that has an impact there. So we've got to holistically manage the patient, and the root cause of all of this causes insulin resistance, and as a result of that, we are finding that it causes a lot of chronic diseases such as obesity, migraines, heart disease, high blood pressure, stroke, sarcopenia, etc. And so educating the patients around this and how certain lifestyle habits or lack of can have an impact on your health. So just want to talk about a case study about a patient. And these are typical patients that we see in our type 2 diabetic cohort. So this is a gentleman, 55 years of age. He used to do night shifts. He had ischemic heart disease, type 2 diabetes, hypertension, sleep apnea, and knee joint problem. So this was his medication: amlodipine 10 milligram, aspirin, atorvastatin 20, citalopram 30 milligram, lisinopril, metformin. Your typical medication list for a lot of our patients that are suffering from chronic disease. So we took his parameters before the program started, and his HbA1c was 105. His LDL was 4.0, the triglycerides were 2.2, his weight was 111, his liver function was slightly raised, and his blood pressure was high. And when we took his bloods and his HbA1c was 105, this is at scary levels now. And so we had a conversation with him to say, I don't think you're probably suitable for the program. We need to look at potentially insulin here. We need to look at up titrating your medication. But he insisted that he didn't want to take any insulin, and he's going to commit to the program. And after several discussions with myself and the diabetic nurse, we said, okay, patient choice, no problem. But he's very well aware of the risk. And so this was his typical diet throughout the day. So that picture on the right hand side, that's a typical plate that I eat, which I've calmed down now. But I love my chicken burgers with halloumi cheese inside. But he had bran flakes, typical cereal, orange juice, porridge, banana, sandwich, Coke, crisp, chicken and rice, fizzy drinks, chocolate. Loved his samosas. Has his 2 teaspoons of sugar. And I think a lot of people's diets can resonate with this. And my question to you guys is, how much hidden sugars do you think he's having in a typical day? You can speak out, you can leave it in the chat. Let me know your thoughts. So, how many teaspoons of sugars do you think he's having on his typical diet in a typical day? Any guesses? No worries. I'll assume you've got the sugar
There's a
spoons.
there's a few coming
Uh,
through the chat, Ishaq. So 20 teaspoons, 15 teaspoons,
Okay, okay. That's what.
35.
So make a note of what you put originally, and I'm sure you're going to change your answer very shortly. So this is cereal. So in a 30-gram serving size bowl of cereal, he was having bran flakes, and that's the equivalent of 4.8 teaspoons of sugar. Cornflakes is again 8.4 teaspoons of sugar. And when we were explaining this to the patients, and when you visualize it in this manner, they were shocked. They were like, "Really?" And we tried to, so we have to educate them that when you're buying certain foods, you've got to look at the sugar amount that's in there. And if you look at what's going on right now with our children and oral health and around poor choices of food, these are all staple foods that we give our kids. I know myself, my friends found me a bit weird because it's only up until 3 years ago I couldn't sleep without having cereal. I always like to joke like cornflakes was my Zoppy clone. And I blame my mum for that because my mum said I was a bad baby. She said, "You never used to sleep, you were crying. And the only thing that would keep you quiet was a bowl of cereal." And it took me almost 30 years to get rid of the habit. But yes, cereal has a lot of hidden sugars in there. Cornflakes, which is very common. And what I'll also say is 30 gram is a modest size. I think a lot of people will have a much bigger bowl than that. Let's move on to some of the other staple foods. So basmati rice, served in a 150-gram a plate full, and that's equivalent of 10 teaspoons of sugar of hidden sugars. Potatoes, 9 teaspoons of sugar. So as you can see, the narrative is adding up now. Um, let's move on to our everyday fruits. So like bananas has equivalent of hidden a teaspoon of sugar of 5.9, grapes 4.0. And so what I what I want to make absolutely clear to everyone that there's nothing wrong with eating these type of foods because, in moderation it's fine. However, if you are finding with your patients that despite them being on medication, despite them telling you that they're eating well, we need to do a holistic approach in terms of what are they exactly eating to make clever changes to their dietary habits, and that can have an impact in improving their type 2 diabetes. So we put this table out for them to visualize it even more. And a lot of our patients were visual learners. So we got sugar cubes and we put the different variety of foods that everyone has. So some of the people on our group love their monster drinks and their Starbucks macchiato and potatoes, etc. And when they visualized it in that manner, they were quite shocked that actually, when you actually explain it like this, we actually didn't realize there's that amount of hidden sugars in there. And this is where the education around carbohydrates and how they have an impact internally and when you break it down. So that education is key. And for our patients, it was kind of like an eye opener for them. So we made some changes to his diet. So we agreed that, and this is what we did for all of our patients. So he changed to like having egg, low carb granola, chicken salad. For dinner, he attempted cauliflower rice, but he said, I didn't like cauliflower rice, so that's fine. He still had his normal rice, but he reduced the amount of the rice and increased his meat portion and salad. And he still had his chapatis, but he just reduced the amount that he had. And he switched to decaf coffee, and he did try dark chocolate, which he took a liking to over time. Now, my next question to you guys is this. After 3 months, his HbA1c was 105 and his weight was around 112 and his blood pressure was around 149 over 89. What do you think the reduction in the HbA1c was after 3 months? And this is just through diet intervention.
So again, feel free to maybe put your guesses in the chat. Remind us again what the HbA1c was to
So
start with, Ishaq.
105. Yeah, HbA1c was 105. His weight was 112 kilograms and his blood pressure was 149 over 89.
Okay, I've got 85, I've got 95, I've got 60.
Okay,
Yeah.
excellent. Brilliant.
Oh, 75.
75. So you're all wrong.
Wow.
So his HbA1c went down from 105 to 39. And I was shocked. I just thought, is this normal? And so I got in contact with a GP who's based in Southport called Dr. David Unwin, fantastic GP. And I said, do I need to send this person to hospital? Because I've learned in the literature that when someone has a rapid HbA1c reduction of that much, it's quite worrying. You don't want to rapidly reduce someone's HbA1c in such a short space of time. But I said, does this happen? Is this normal? He said, yeah, because you can reverse type 2 diabetes, put it into remission within 3 months with strict lifestyle intervention. Now, this is an exception in terms of the amount of how much is reduced by, but still, this was remarkable. And you could tell by looking at him and how he was. And one of the interesting things that I'll never forget what he said was when he changed his diet, he lost his brain fog, he had clarity of thought, and he just felt a lot better mentally, which was really, really interesting to hear that. And so, really encouraging. And it wasn't just, like I said, the HbA1c reduced, he lost 12 kg, but that's expected, an average of 4 kg a month. His LDL levels went down to 3.2, so still slightly raised, but there was a reduction. His triglycerides went down, and his blood pressure reduced to 118 over 80, and that's expected. For every kilogram that you lose, then they say at least you reduce your BP by 1 mmHg. So it was remarkable to see, and so we did some deep prescribing. So what we did was we followed him up. I reduced his amlodipine to 5 mg. His blood pressure was still fine. He was on metformin 2 twice a day. I've reduced him to 1 twice a day and then checked his HbA1c 3 months later. And then we stopped it and then we checked it again. And still his HbA1c was below 42. And then we had a reduction plan with citalopram. He wanted to stop it altogether, but I explained to him that we don't all of a sudden stop antidepressants. We need to manage it slowly and just to reduce any withdrawal symptoms. And so, yeah, it was remarkable. And that wasn't just that patient. These were several patients that attended the program. Some were around 85 and they went to 59. Some were just above 70 and they went to 55. Some were above 60 again, 55. Someone was above 50 and got to 42. And that blue line in the middle was just a patient that just didn't change at all. He was like 42. Um, and we've run these groups several times and similar results. We see a downward trajectory in their HbA1c results, and those that are consistent that we follow up have managed to either get their type 2 diabetes in remission or they get to around about the pre-diabetic stage. And some patients, they get to around about 48, 50, still they may need to be on the metformin, but don't need to be on as high a dose. And the patients love it, and we have a celebration at the end of it, and we have a nice, healthy, nutritious meal, um, and everyone's happy. And this was just myself and a practice nurse. If there's a gift to describe how we were shocked by everything, we were just amazed. And I'm very big advocate for group consultation because it just adds an additional armory to your bow on top of what else you may be doing in your practice. And I guess my top tips that if you are thinking of doing or conducting group consultations, start off simple, small groups, be open to feedback, timetable your meetings, so make sure you have protected time, especially in primary care that can be challenging, but we made sure that we had protected time. And I was very fortunate to have supportive partners that would allow us to do these type of projects. Confidentiality is key. Make sure everyone signs a confidentiality agreement. Manage expectations. So we made it very clear to everyone that this is group consultations. You know, we don't talk about other patients' health or, no discussing confidential information. And also, this is a program. The more you put into it, the more you get out of it. Document findings. So you have to document the consultation because you've got 10 people there. So you have to document exactly in each person's notes what was discussed by the clinician, and if there's anything that needs to be added from the patient specifically, you can add it on there, especially when we did the 4 weekly weight and blood pressure. And keep going, because sometimes you think, why am I doing this? But then it's worth it at the end, especially when you see positive results. And even if you don't get positive results, it's still very useful to build that relationship with your patients. And what was really nice to see with our patients was when we used to do the next group, the original group would come and showcase how their experience was and encourage the other members. And then you built a pool of people that were part of a what we would call a cult of the type 2 diabetic group consultations. And lastly, celebrate success. So this was an ambassador from, she's a retired nurse, Carol, who was amazing. And so when we did a party at the end of it where we cooked and had a nutritious food, we embarrassed her with some flowers. And it's always important to recognize everyone's contribution when we undertake such great work. And a lot of our patients were quite jealous that these guys were treated to some lovely food. And then we had a big waiting list for people wanted to go on the program. Probably not so much to go on the type 2 diabetic program itself, but more so for having the lovely food that was cooked by the local chefs. But yeah, yeah, that was it. And so for me, this was probably one of the most fulfilling projects that I've done, working in primary care, because when you see the impact that you have with people, but then you'll be able to enjoy the process along the way. And also from a clinician point of view, you are killing 10 birds with one stone in that 1 hour rather than having separate consultations. So yeah, thank you very much. And I'm open to any questions.
Thank you so much for that, Ishaq. I mean, it's really quite shocking in a good way. Those numbers are really kind of unbelievable, aren't they? So does anybody have any questions or maybe like to share any similar work that they are doing? Anne, go ahead, please. And do feel free to put your cameras on if you wish. You don't have to if you don't want to, but do feel free if you would like to. Go ahead, Anne.
Hi, thanks very much. I missed the very start, so apologies if you covered this, but did you run the sessions in a general practice setting or did you run them in a community setting somewhere?
So it was so from the general practice, but I was very fortunate where we are. We have a community hub. So in the building, it has
Okay.
3 floors. So on the third floor, you have assisted living, and then the first floor was a GP practice, and on the ground floor, it was a local library, local cafe. And so a lot of the public health groups, the charities, we all use that building, so it's accessible to everyone. So yes, through general practice, but within that building was part of a community hub.
Yeah, no, that's really interesting because I guess I'm in Scotland and some of the barriers that are cited are around about accommodation.
Yeah,
But we have the offer really to use spaces like library networks and leisure centres, etc., as well to run some of this thing. So I think sometimes the barriers are of our own doing, other than that we can't find other spaces to do these things in. I was just going to ask another question, if that's okay as well, and it was about the dietary aspect that you cover with the participants. And I've heard quite a lot of evidence that as healthcare professionals, we're not trained very well in understanding nutrition ourselves to be able to give the right information and the right information in the right way to people around that literacy about nutrition. And I just wondered what your thoughts were on that, because certainly I don't really ever remember being trained in nutrition, and I think there's still a lot of myths, even with healthcare professionals and their understanding of nutrition as well. So I guess I'm just interested in whether there's more we could do around that kind of training and awareness between ourselves to allow that kind of intervention to happen in the moment as well, because I feel that a lot of this is still having to be done retrospectively. And how do we kind of get upstream a little bit in that kind of both, I guess, that identification and that education part earlier on when people start to present with things like hypertension and
yeah,
obviously we've got a huge epidemic with like weight and obesity, and we've got this distraction of GLP-1s just now going
yeah.
on, which means that we maybe are less focused on the kind of educational side of it. So yeah, I was just interested in that kind of
Yeah, so
piece
very,
around.
very good question. So equally myself, I'm a pharmacist by background, and certainly in my degree, nutrition was not talked about, and I went to one of the red brick universities. So, and certainly in the curriculum aspect, they will touch upon your generic stuff like hypertension, your DASH diet, salt intake, etc. But I've never seen a detailed module done somewhere yet. Correct me if I'm wrong, Noala, you're in the academia space. And so what really influenced me when it came to nutrition was that conference I went to in Solihull, where they had the dietitian, the nutritionist, and other people that are working on this particular aspect. So the person who came to deliver, who was Carol, she was a retired nurse, but she's also done nutrition courses, and so she was very well versed. And I feel like certainly for us as a practice, we have learning on lunch, and we invite, and usually pharma sponsor those events where you have a consultant, but we invited a dietitian, and from hearing from a dietitian point of view was really, really impactful. And what you'll find is that there's loads of different camps. You'll find that so Public Health Collaboration UK are very big on low carb. That's kind of like the message they talk, which is fine. But then you got to also look at other aspects. So in our area, we had lots of African Caribbeans and also South Asians. So we worked with the African Cancer Society, and then they had someone that was a nutritional expert that would educate around certain food dietary aspects in their culture, and same from a South Asian point of view. So I do feel that there's more work that needs to be done from a healthcare professional point of view in terms of education, especially for the type 2 diabetics, because there's lots of foods that people are having, but we still need to appreciate how carbohydrates work and the impact, because some patients may not be able to have as much as carbohydrates as someone that's healthy and doesn't have any multiple comorbidities. So I think there needs to be a lot more. And I was speaking to Noella before you all joined the call, that before I certainly feel that there was so much emphasis on lifestyle and there wasn't enough attention given to medication. Now I feel like it's gone the other way, where certainly where you see on YouTube and Instagram and all the social media posts that GLP-1s, and it's got the headline. But then if you look at the principle of GLP-1s, in order for that to be worked effectively, you need to work on a root cause analysis, which is mainly your diet, your hydration, your resistance training. And I think that message needs to be passed more to us as healthcare professionals. And I would certainly encourage you to reach out to local dietary dietitians or nutritionists that are experts in this area that have a holistic viewpoint, because that way they can cater to different people's needs. And because low carb is not easy, I tried it. It's so hard. So if you've got someone that has a good understanding of a variety of stuff, then invite them to the practice. I will share some resources after the call, and hopefully Noella can share it out. But there's some people that I do recommend. There's a really good dietitian called Trudy Deacon, really, really good. And she can get, I think she can source funding for PCNs and stuff if anyone wants to have more of a input from her. I'm trying to think who else is there. New Forest PCN. New Forest PCN are fantastic. They have really good resources, but I'll try and share some more if I can. But no, it's a good question. And I think that I encourage Noella to get a good nutritionist or a dietitian and to talk about this aspect, because I feel like more than ever we need to know about this information.
Oh, that's helpful. Thank you.
Yeah, I think that's a really great point, and certainly, like I, as you say, work in pharmacy academia, and there's very minimal amount of training around diet and nutrition, and I'm kind of very keen to change that. And I think that really applies across all the health professions. And if you talk to most medics, they'll say the same.
Yeah.
So people have a sort of very sort of superficial understanding. I've put a few links in the chat that are specifically around plant-based diets. And I was just going to ask you, Ishaq, if you had sort of any experience in terms of sort of working with plant-based diets or encouraging patients to go for the sort of whole food plant-based as opposed to the meat and dairy. Obviously that's kind of coming from a sustainability point of view, but the health benefits are really positive as well.
Yeah, so we did have a couple of patients that they were mainly eating from a plant-based diet. And so some of the nuggets that I learned from there were I remember the nurse saying, remember these points. If it grows overground, eat as much as you want. If it grows underground, try to have that in moderation, and we used to explain why. She said the vegetables that grow on the ground, like your potatoes, the carrots, etc., they're quite sugary in nature. But yeah, and it does work. It works wonders, and they had really really good results. So yeah, we did have a few people with plant-based, and certainly myself. Um, I've taken an active position to reduce my meat consumption, and I do feel a lot better in that regard as well. I try to treat it as a luxury, and I guess if you look historically, meat was luxury, wasn't it? It wasn't something that was intended to be eaten every day. It was something that you'll have on a rare occasion because it was a luxury food item. So yeah,
Yeah.
certainly in our family, we have our lentils and lots of plant-based food, and so and same in the South Asian community, especially from the Indian and those that are Hindu practicing. They rarely had meat, and so they were having lots of vegetables and curries to help
Yeah.
with that. Yeah.
Yeah,
Uh,
I think it's the volume, isn't it, that people consume now in terms
yeah.
of meat. Like you only have to go back really to, our parents or grandparents' generation. And like you
Yeah.
say, meat was a luxury. You maybe had meat on a Sunday and then you used the leftovers through the week. You weren't eating massive portions of meat every day, a couple of times a day, 7 days a week, which is what people are doing now, which I think is the
Yeah.
issue.
Yeah.
Somebody has popped in the chat box a link to Dr. Alex on YouTube. I'm not sure if you've come across Dr. Alex on YouTube, Ishaq. I think I might have actually. I think he
No.
talks about all sorts of stuff, so maybe worth looking at.
No. I'll check him
um,
out.
any other questions? I'm just going to jump in with a question for Ishaq while people are having a think. I was really interested in the sort of the group consultation aspect of this, and maybe the sort of psychology of being in a group and how maybe that affected people's behaviors, because I think we all know how hard it is to get people to change their behaviors. So what difference do you think sort of having that group approach made?
Yeah, it's a good question. So in the beginning, a lot of people were on the fence, a bit shy. And then what ended up happening was you find one or two people that were really engaged, and then they lifted the rest of the group. And then what ended up happening at week 4 when we were checking everyone's weight and blood pressure, they were like, "Oh, what was your weight?" And they were like, "Oh, what was your weight?" And then it became a bit competitive. And so they were comparing with each other for the next weight request. So yeah, it was. I think it was good in that respect. I think eventually what ended up happening by the end of the 12 weeks, a lot of them were sad that it came to an end because they built a really good relationship and a bond. The bit that we did find challenging, however, was you get one or two people that are asking lots of questions, and then that will then teeter into like a side chat. So we had to kind of manage that. So initially we said, ask questions whenever you want, but then we managed it by saying, let the speaker just complete what they do and then write down your questions, and then we'll answer as best as we can. So yeah, that's probably for my take on from the psychology of it, that they became very competitive towards the end, and
Yeah.
they were encouraging everyone.
Yeah. Well, that's really interesting, though, isn't it? Just that sort of group approach and the social interaction, I think,
Yeah.
is really important. And seeing other people doing it, because that's how we change our behaviors, because we look at what people
Yeah.
around us are doing and we copy them.
Yeah.
So I think it's a really great approach. And I really just like that it aligns so well with that sort of patient empowerment principle of kind of really giving patients the agency to make the changes themselves in their own lives,
Yeah.
rather than relying on, external intervention.
What I forgot to mention was we managed to ask the Abbott rep. So if you're good friends with the local Abbott rep, she gave me around 20 freestyle Libra 2 meters
Uh-huh.
as part of the pilot. And so that was really good as well, because what we said to them was put the freestyle Libra on your arm. First week, just eat whatever you want, put down your sugar levels, let's have a look. And then second week, change your habit and see what the sugar levels are. And they've seen a difference, which was really, really
Right.
interesting. And if you guys have never used a Freestyle Libra, you can get one for free as a healthcare professional. And I encourage you to do it. And I always find that when you do something yourself, and even with some of these dietary advices that you may give to patients, when you actually try it yourself, you can live the experience, and then you'll be able to better articulate it. And so you do it, and you'll be shocked by certain foods that you may eat that might cause those sugar spikes. But for healthy individuals, it'll quickly come down. But for some of the patients, what they found was very interesting. One of them had ice cream, but it didn't do anything to the sugars, which I was quite shocked by. Where someone else had ice cream and the sugars were really massively impacted as a result. And I guess this is probably going into the future in terms of genomics and genetic testing and seeing what
Yeah.
foods are right for individuals. But I do encourage you guys to, one, become good friends with your Abbott rep if you can, and then try the Freestyle Libre 2 sensor or the Dexcom, whichever one you can. It's a real eye opener, especially for your patients as well.
Okay, great. That just reminds me as well, Ishaq, I was going to ask any links. I'm happy to share them. I will put them up on the network. I was interested if you have the link to those lovely infographics you had on the sugar content of different things, because I think they're
Yeah.
really quite shocking, aren't they? And so I think they'd be really useful to share if you can. That would be great.
Yeah, I've got the link. I'll share that with you. Yeah.
Great. Okay. Last call for any other questions. Oh, Anne is asking, were there any challenges with attendance? So
no, all of our guys attended. However, I was anticipating lack of attendance. So what I did was I used to send them a pre-scheduled message the day before and on the day of when the session was. And if nobody had come by that particular time, then myself or the practice nurse would ring them. And so, and there were a few phone calls were like, oh, completely forgot, really sorry, and they'll come. But that wasn't a majority, thankfully. That was just probably one or two people that forgot. But yes, I do encourage you that if you are doing this, then I wouldn't rely on patients remembering. So you will need to be proactive. If you've got Accurix, that's what we have, or you've got a messaging system in part of your practice, then do send regular reminders.
Okay, great. Thank you, Ishaq. So I don't think there's any more questions. So I'm going to say thank you so much to Ishaq for sharing your experience and knowledge with us. If you send me any links, what I will do is I'll put a post up on the network, on the pharmacy network, for everybody to see.